Yes, because I can move, otherwise I cannot move. Thank you. I just will present what is the experience of the Spanish Center being part of a program that has been led by the Canadians, and we are acting as a host in our country, and I take you the experience for the last 10 years, yes, almost 10 years, no, 8, that means it's a little bit less. We are using, that means we take with the previous presenter, we are using for this program, and because the Canadian is using for this program the model Knowledge to Action. Maybe you can see what is in the real life, they're using this model for implementation. The overall model is taking this idea. It is the guide development from the beginning, the implementing, dissemination, implementation, and sustainability. We are evaluating and monitoring which is the implementation process, and finally we are looking for the impact in patient and system. The guideline has been developed by the Registered Nurses Organization of Ontario. Take these 3 types of recommendation. This is practice recommendation, educational recommendation, and organization and policy recommendation. And we are developing these 3 indicators in these 3 areas up to evaluate the implementation. Our unit, just to pick you a little bit in context, our unit started to create a new knowledge 23 years ago, because when we were at the beginning in our country, we are not master degree and not doctoral degree. That means the nursing research was not very good ones. That we decided that the first step is to create new knowledge. And when we arrived to have a new knowledge, we started to disseminate it, but we think we need to use the best available knowledge. And we signed the agreement before with the Jean Abric Institute, and after with the Registered Nurses Association of Ontario. And we are working now more in implementation, doing from the new knowledge to the best available knowledge. This is the structure of our center. I think it's a center different from the other centers in European countries, that we have a national center. When we started to create the JVI, we signed the agreement with the JVI, and after the agreement with the JVI, we have signed an agreement with all regions in Spain. That means we take a national broad levels for our center, and we create a Spanish center for evidence-based nursing, and we included all professionals in this center. That means we have a broad scope that is a national one. The history with the Registered Nurses Association of Ontario started in 2010. We signed an agreement with them and with the Institute for Health Carlos III, that is the place that I work. And we decided it will be also national scope, and the agreement that we make with them started to be, because they have been some experience having best practice organization, best practice pilot organization as a direct center, but have not been never ever to have an experience with a full country. That means we sign this agreement, and they call us best practice or pilot organization host. And this is the experience I will tell you. This is Spain. That is looking different, very different from my point of view. Okay, we have 17 regions, we have universal coverage, we have, our system is financed by taxes, and 70% of our services is going to primary health centers, 20% is going to patient consultation, and 10% of the services is going to the hospital. The aim of our project was to adopt best practice guidelines, guidelines into our country, to our public institution, in order to promote excellence in practice and better patient outcomes. And the strategy was to be this host organization. The strategy takes into account different parts. That means the program is leading by nurses, but it's a multidisciplinary program. Any professional working in different institutions is working on it. there is they plan to start it with few things, and they are growing up in the 3 years. There is bottom-up. That means the call we are open is not from managerial bodies. It's just for nurses who convince their managerial to go to our programs. This is context adapted for sure. That is taking some other stakeholders. And they have continuous support for us. That as a host, we are working with them monthly. That means they have very good support from us. And it's based on something that, a figure that Canadian people tell champions. And champions are people working in the institution who are helping us to implement these guidelines. And it's, okay, this is a participatory process, and it's a national and international benchmarking that is good for us, very good for us. The project until now is like this one. There is 26 institutions, as broader institution working with us after 3 years. That means at the end we have 38 hospitals. Primary health center we have 231, that means it's a lot, and we have two universities. And finally, we have a lot of professionals involved and trained by this model and working in different levels of this program. And we have some students who is coming from the universities going to go practice in the institution, and are also implementing guidelines. And the coverage population is about 8 million. That means it's not too bad. This is the best practice guideline we are implementing. The centers, every center should implement at least 3 of them, and the most popular one is breastfeeding, ostomy, and falls prevention, and some of them vascular access. The guideline we are implementing, we can be putting like a health promotion, chronic care, safe provision of care, and continuity of care. And after being working 8 years, we realized that the model we are taking takes us too much at work, and that is growing very fast, and we cannot take the same level of continuity of level of support for each one center that we have developed, and we will start to develop in 2009, the next year, a regional level in between the Canadian level, our level, and the institution who is working. Because you work with them 3 years, but when you finally decide that this institution can be a best practice organization, pilot organization, you need to renew every 2 years. That means you take 8 at the beginning, 10 more, 8 more, and anyone you are taking, you are adding more work to our institution. That means we cannot be very sustainable model, and we decided to create something in the middle. And this is the idea now that will be started next year. We have created a regional BPCO host, a national BPCO host, and a best practice organization institution. And the support and mentorship is divided by us. We are still having some direct BPCO because still at the beginning, but when a regional will be, 3 or 4 years working as a host, they will take all these BPCO, best practice organization, pilot organization under their mentorship. And I think they are now 3 completely region who will start it in 2009. That means they will give us more opportunity to grow. We have created this kind of model for trained people because we need to train people for implementation and also for auditor and evaluation leaders. And we have created this kind of cascade model that will allow us to train more people and to have more people helping us. There is some results. That means for falls, we we need to adapt clinical records, support committees, protocols, reviewers. This is a lot of things we have to do in the in the area of falls. That is the changes we have been in the assessment at admission and the risk patient, but the most important thing is results on real results on patient. Among the 3,000 people who was at risk at the beginning, at that moment only 95 people has already fall, but just one of them has severe injuries. That is the best data we have about falls prevention. For breastfeeding, they have changed from the baseline was 44, and we go to this 47, and we have been exclusive breastfeeding assessment has now on the level of the World Health Organization asking for us. And I think the most important things in the overall ones was the things we have been able to change at the level of institution of policy. That means we have created stables, a team, very good teams. We have improved managerial bodies. We have improved physical structure to allow those people to implement guidelines. We have educated thousands of nursing and other professionals, students, even cleaner people are helping us too much to implement guidelines for falls prevention. We have disseminated, we have a lot of activities dissemination this evidence and this recommendation, and we have improved the research capability for those nurses and for those professionals working in this institution. We have updated many protocols. We have involved many stakeholders. We have patient education and empowerment of them. We have harmonizing records. I don't know in your country, but in our country we have 17 regions and we have 17 health systems, different health systems. Any one of them is collecting data in different systems. That means to put all those records together has been a very long way, and we are now some harmonization between records and between regions, new clinical records for those who need to collect data for evaluation. We have adapted the international indicator to our national indicator. Okay, and we have some doctoral students in the program now, and we have 3 or 4 research projects who has been funded at the national level. But I think the most important, and just to finalize with the results, is we have really be able to change the evidence-based cultural idea about nurses and professionals. We have more institutions trying to work with us in this program than those who really we can take. That means this is like a waiting list every 3 years to go to the program, and they are doing some few things, but there are even changing some, making some recommendation and implementing some recommendation. We have been other institutions who are not BPCO that can be not be in the program because there are private one who is trying to work with the same program, and there is starting some collaboration between those who has been already recognized as a best practice spoiled organization with those new organizations who is trying to work together. For the first time in our experience, that means we have been able to put nurses from different regions working together. That is almost impossible, and was almost impossible some years ago, and nowadays there are monthly meetings by areas of the guidelines, and you see people from different regions and from different culture and from different ideas working together, having something, doing something together, and for me it's the most important thing. And also we have some community of knowledge around this topic that I think is also very important. And the things that I told you, the most important also for patients is there are some outcome and some data that is collecting in the same way in different institutions. That means if you move from different regions in Spain, you have your record and you have the same way that they collecting data, nursing collecting data. I'm not sure in other profession, but nursing in this center are collecting the same data and can be compared between their own institution and the international institution. And this is the things that we have doing with this 8 years. And I think this is a program that has already became to our country and will stay there and we will grow up. And I think with this new version of regional host, we will be able to have almost all public institutions in Spain included in this program in the next 8-10 years. Okay, thank you.
Thank you very much, Maite. Then we have some time for questions. Any questions, please?
Thank you, Maite. That's an incredible project. It's just a huge amount of work. Have you sort of built in plans for continual evaluation to make sure that you can sort of continually improve? Because there's just so much involved, isn't it, right over Spain? It's an amazing project.
Yeah. For those who are in the candidate process, we collect data from them since the 6 months. At the beginning, we just giving them some advice how to evaluate it. And when there are 6 months, 8 months, we collect data monthly. There are sending for the database the last 5 days of each one month. And they collect data monthly during the period of candidate, that means during 3 years. And after these 3 years, depending on the guideline, but they are still collecting data 6 times a year. That for those who have already started in 2012, we have 6-year data. For those who have started in 2015, we have 3 years data. And for those who are starting now, we have just 1 year data. But they would need to, in order to be renewed, they need collecting data at least six times a year. And for the five last days, working days in every month. That means there is like about 10–15% of the patients we have data of them. But this is few indicators. It's not a long way of indicator. That means every guideline has maybe 3 process indicator, 3 outcome indicator, and some structural indicator. Yeah. But we're still collecting data. That means, and it's not aggregated data in our case. It's patient data. That means we can, if anyone like to study or make some research in them, they can go back to the record if they need some more information about, I don't know, some disease of this patient or whatever they need about. And for those guidelines like obesity, ostomy, I don't know which more, we have cohort data. That means when there is a patient with an ostomy, they will be in the system during the time that it's going to visiting the outpatient clinician. That means we have few cohort of them, but we have some cohort of the obesity, children obesity, ostomy, and diabetic foot.
Some other questions? Well, then I have a question. sorry. The RNAO program is used all over the world. Huh? Is there a good collaboration between the?
Okay. The program started in Toronto, and they have some international center, that is Australian center, different centers in Europe. One center in Europe, that is Belgium, I think. We started. There is different ones. But for us, as a Spanish one, the most important thing, we have a very good collaboration with the Spanish countries, Latin American countries. When we signed the agreement with the RNAO, with the Registered Nursing Organization of Ontario, we decided and we put as a condition that all the guidelines will be translated really without not adaptation to Spanish culture, will be just translated and back and translated. That means all the Latin American countries and all these who speak Spanish can use this guideline. That means we have Chile, Colombia, I don't remember, Uruguay, I think is another one. I don't remember, but we have very good relationship also with Latin American countries. Yeah, but this is growing up and is at the international level. But we have the best relationship and the best. But you can compare. This is one of the ideas for us. You can compare for anyone in the world who is working in the same program. The Canadian Association has the data for all of us, aggregated data, and you can asking. You can compare you with another institution, yeah, and they give you the permission, and you can compare what is your personal data, your specific data, with the data from other countries. Yeah,
that's nice.